When talking about collaboration and connection, it's going to be really important for us not only to collaborate together within this room, but also with our partners, our collaborating organizations, our networks of people living with HIV, and our federal partners who are here in the room today. I'd like to thank them for being here. I'd like to acknowledge Regional Director Michael Kapanargi of HHS. Michael, if you could just take a bow. Thank you. So it's really important for us as we, start to prioritize and implement these changes that are going to affect the quality of life of people living with HIV and aging with HIV, and particularly long-term survivors, that we have our partners and we're working with partners. And the fact that they are in the room here today shows their dedication to that. So once again, thank you. I'd like to now introduce our keynote speaker. Adrian Shanker is a senior advisor on LGBTQI+ Health Equity in the Office of the Assistant Secretary of Health at U.S. Department of Health and Human Services. In that capacity, he advises Assistant Secretary for Health, Admiral Rachel Levine, as well as OHSH staff on LGBTQI+ health policy and providing staff-level leadership to the department-wide HHS LGBTQI+ Health Policy Coordinating Committee. Before joining the Biden-Harris administration, Adrian led LGBTQI+ community centers in Allentown, Pennsylvania, and Marin County, California, and served as board president of Equality Pennsylvania. In Pennsylvania, he served in two capacities in Governor Tom Wolf's administration as commissioner and health committee co-chair of the Pennsylvania Commission on LGBTQ+ Affairs, and as commissioner on the Pennsylvania Human Relations Commission, a post to which he received unanimous confirmation from the Pennsylvania State Senate. That is no small feat. He also previously served as a member of the Presidential Advisory Council on HIV/AIDS, otherwise known as PACHA. And Adrian earned his BA cum laude in political science and religion studies from Muhlenberg College, earned a graduate certificate in LGBT health policy and practice from the George Washington University. He's published numerous articles and edited two anthologies on LGBTQI+ health policy, Bodies and Barriers, Queer Activists on Health and Crisis and Care, Queer Activist Responses to a Global Pandemic. And he was named Person of the Year by Philadelphia Gay News in 2012 and again in 2018. Please welcome, put your hands together for Adrian Shanker.
I didn't know my photo was going to be up there. So, good morning, and thank you, Jeff, for the introduction and for welcoming me to join you all today. I'm really excited to be here with the Reunion Project for your Chicago convening for an important conversation about health equity for people living with HIV. I'm Adrian Shanker. I use he, him pronouns, and I'm honored to serve in the Biden-Harris administration as Acting Deputy Assistant Secretary for Health Policy and also as Senior Advisor on LGBTQI Health Equity at HHS. By way of visual access, I'm a white man wearing a navy suit, purple shirt, and a blue tie. And I want to start by acknowledging that May is also Asian American Pacific Islander Heritage Month and recognize the countless AAPI advocates over many years, both inside and outside government, who worked to advance health equity for people living with HIV. By way of introduction, just about me, you heard a little bit, but I'm a former PACHA member. I led an AIDS service organization in California that also ran a harm reduction program. I've led LGBT community centers, and I've worked with caucuses and organizations of people living with HIV for many years. I'm proud to serve in the Biden-Harris administration, which is the most diverse administration in history. It's an administration that's been clear from day one that health equity is central to our work. From President Biden and Vice President Harris, Secretary Becerra, and my boss, Admiral Rachel Levine, they've all made that very clear. In fact, at HHS, every policy proposal that we put forward, we have to have a written demonstration of how it will advance health equity. On President Biden's first day in office, he signed an executive order advancing racial equity, and supporting underserved communities through the federal government. Among other things, this executive order called for an equitable data working group, stating that the lack of disaggregated demographic data has cascading effects and impedes efforts to measure and advance equity. A first step to promoting equity in government action is to gather the data necessary to inform that effort. The president's executive order emphasized the enormous human costs of systemic racism, persistent poverty, and other disparities, and directed the federal government to advance an ambitious whole-of-government equity agenda that matches the scale of the challenges we face as a country and the opportunities we have in front of us. In 2022, the president signed another executive order, this one advancing equity for LGBTQI plus individuals. And this executive order calls for action to address the significant disparities that LGBTQI plus youth face in the foster system, misuse of state and local child welfare agencies to target transgender people, and the mental health needs of LGBTQI plus youth. This order also calls for safeguarding LGBTQI plus youth from the harms of conversion therapy. HHS has been delegated bold deliverables under this executive order, and while many of them have been completed, we are still working diligently to implement the president's vision for equity through this executive order, and to support the health and well-being of all people who live in America. In his 2023 State of the Union address, the president called for numerous health equity measures, including capping the cost of insulin at $35 for everyone who needs it, prioritizing the removal of lead pipes in America, in American public schools, and ensuring that veterans have access to mental health and suicide prevention services. He spoke about the importance of enacting comprehensive non-discrimination protections. And we know that discrimination is a public health issue that disparately impacts historically marginalized communities the most. I want to speak directly to our work addressing quality of life improvement for people living with HIV. President Biden's national HIV/AIDS strategy calls for efforts to address quality of life factors, and many of the national HIV/AIDS strategy deliverables are delegated to HHS. A few examples of some of our progress are some of the final rules that we've just completed in the last few weeks. HHS promulgated a brand new conscience rule that centers the needs of patients, ensuring access to care. The prior administration's conscience rule invited discrimination, and our rule centers access to care. We still maintain that providers with deeply held religious beliefs can arrange for a colleague to provide care in instances where they have religious objection, but the care of the community comes first. This is especially important when it comes to HIV medicine, both on the prevention and the care side. We also just finalized a new 1557 rule. 1557 is the healthcare non-discrimination section of the Affordable Care Act. And our new rule extends the Bostock definition of sex discrimination to include sexual orientation, gender identity, sex characteristics, and pregnancy. This ensures that providers and insurance companies don't discriminate on these bases when providing care. And this disproportionately supports access to care for people living with HIV. We also issued a final rule in the Older Americans Act back in February. This designated LGBTQI plus and HIV positive older adults as populations of greatest social need. This means I actually think this one's really significant because this means that state aging offices, as well as area agencies on aging all across the country, are able to prioritize services for people living with HIV as they age, and to utilize federal resources to do so. We also finalized a new Section 504 rule. This is the first major update to Section 504 of the Rehabilitation Act since the 1970s, and it includes important provisions for people living with HIV. Especially, it provides presumptive protection for all people living with HIV, regardless of detectability status or CD4 count or any other co-occurring disabilities. Our 504 rule confirms that HIV stigma or fear of providing care for a person living with HIV is not a basis for providers to avoid providing that care. Well, while not all people living with HIV self-identify as disabled, the disability protections in the law provide essential healthcare civil rights protections for people living with HIV. In addition to these regulatory changes, we're continuing to work in other areas as well. For example, the President's Advisory Council on HIV/AIDS recently added a subcommittee specifically looking at HIV and aging. The United States Public Health Service Commission Corps, of which Commander Trail is one of our commissioned officers, ended its medical exclusion for people living with HIV, becoming the first of the United States Uniformed Services to do so. And we updated our guidelines on blood donation to remove stigmatizing and outdated presumptions about HIV seroconversion. Our new guidance removed longstanding time-based deferral for people living with, for men who have sex with men, in favor of an individual risk assessment where everyone, all blood donors, are asked the same questions. And while we know that these rules don't mean that everybody who wants to donate blood can do so, I cannot donate blood under the new rules. It's not because of outdated science. It's not because of stigmatizing discriminatory frameworks. It's because of actual scientific risk. And so we've really tried to update the science to look at actual risk instead of bias. We continue to state that U equals U, undetectable equals untransmittable. And in our 2023 interim action report on the National HIV/AIDS Strategy, HRSA announced that they're ending the HIV epidemic grant recipients served more than 22,000 clients new to care and 15,000 clients estimated to be re-engaged in care. In 2023, HRSA also awarded almost $2.5 billion, billion with a B, to cities, states, and community-based organizations to deliver effective and efficient HIV care. Nearly 90% of Ryan White clients who received medical care from the Ryan White providers had at least one viral load test were virally suppressed. 90%. HHS created a new campaign called the Work of Art campaign. Curious if anyone has seen this campaign. Maybe not. Maybe we need to get it out a little more. But the Work of Art campaign, which features people living with HIV talking about the importance of medical adherence to antiretroviral therapy. And HHS partnered with the Administration for Community Living to award $1 million for 2 innovation challenges to improve health outcomes for people living with HIV as they age, as well as longtime survivors of HIV. And there was a special focus on racial disparities within aging with HIV. Of course, we're aware that people living with HIV, like all people, experience co-occurring health challenges, and we want to address those challenges head on. We're working to destigmatize mental health and to ensure that anyone who needs access to care can access it. We're proud of the creation and growth of the 988 program at SAMHSA. 988 offers 24/7 call, text, and chat options to trained crisis counselors who can help people experiencing substance use or mental health crisis or any other kind of emotional distress. People can dial 988 if they're worried about a loved one who may need crisis support as well. 988 began a pilot network to offer specialized call, text, and chat services specifically for LGBTQI plus youth and young adults. And this program supports queer youth under 25 who reach out to 988 and want to speak specifically to someone who's trained in LGBTQ specific crisis care. The Biden administration increased funding for 988 by 18 times. It's a national priority to ensure that everyone in America has access to crisis mental health support if they need it. The Women's Health Research Initiative at HHS, it was recently announced by the First Lady, includes specific interest in research that will improve health outcomes for women living with HIV. And looks at intersecting health challenges that have not always been at the forefront of the HIV conversations because they specifically impact women. So this is part of the Women's Health Research Initiative. And we're focused on addressing syphilis across the country. CDC proposed the first ever clinical guidelines on the use of doxycycline for PEP or doxyPEP for STI prevention, and we hope that these guidelines will be finalized very soon. SAMHSA's HIV program also issued a Dear Colleague letter to all of the HIV program grantees in their HIV program, offering funding flexibilities to support efforts to address syphilis testing and treatment for any of their HIV service recipients, because we understand the syndemic between HIV and syphilis. And we're working on nutrition security and framing it as food as medicine. We've talked with people living with HIV as well as HIV service providers about the importance of food access, but not just food access, but actually nutritional food access, and how important that is for quality of life and quality of care for people living with HIV. Ultimately, this is all about health equity. And the government, HHS, we define health equity as the attainment of the highest levels of health for all people. And we mean all people. We don't just mean some people. So health equity means all people. It's a goalpost we're striving toward, and it's very much an unmet dream. We all deserve to be able to attain the highest levels of our health. Striving towards health equity remains a core priority. Working to achieve health equity will take every one of us. It requires addressing disparities in health, not just health outcomes, but in health access. It means we have to move beyond stigma. Barriers to care are literal stumbling blocks that prevent some people from accessing the care that our bodies need. Stigma, including HIV stigma, is a barrier to care. Health disparities cannot be addressed without understanding the social conditions of our lives. Patient-centered care requires listening to patients to understand in their voices the reasons why care is delayed or avoided altogether. And let's be clear, if a patient, including a person living with HIV, delays or avoids seeking any type of health care because of fear of mistreatment or stigma, that's absolutely and unquestionably a patient safety issue. Ultimately, it's up to healthcare providers and health systems to ensure that patients feel safe. It's not the patient's responsibility to make sure that they feel safe. But it is up to all of us in our community to work to address the social factors of our lives that lead to worsened fears of mistreatment. Ideological attacks on transgender health, continued experiences with conversion therapy, continued HIV stigma 4 decades into HIV, all of these add to a layered feeling among many in our community that the care that LGBTQI plus people receive, the care that people living with HIV receive, may not be accessible to all of us. We have to do better as an entire community to ensure that all of us can access the care that we need. Health disparities aren't just numbers on a spreadsheet. These are people in real life. And we see how health disparities play out. We know that it takes all of us to address health disparities. It takes providers, it takes community, and it also takes each other. We don't address health disparities in isolation. We address it together with HIV stigma to try to achieve health equity. In closing, I want to thank the Reunion Project for the invitation to join you today, and to Commander Trail and Michael Kabanargi for their work locally here in this region of the country to help to ensure that HHS resources get out into community organizations across this region. And I'm happy to take any questions if there are any as well. Do you want that? Yes. Okay, so I'm going to try to repeat the question so folks can hear. But could you? Oh, actually, even better, we have a mic. So.
What is the Biden administration doing to guarantee our access to PrEP in the future? It's already under attack in Texas and Tennessee, much like with the whole Hobby Lobby and birth control. I want to know what the government or what the Biden administration plans to do, because it's time to act now. We can't wait until it spreads to more states, as we can see. So.
Thank you for the question. So PrEP is incredibly important to us in this administration, has done an enormous amount of work to advance access to PrEP already, including the FDA's approval of the first ever long-acting injectable PrEP. U.S. Preventive Service Task Force grading of PrEP is grade A. It's the highest rating that they give, saying it's safe and highly effective at preventing the transmission of HIV. HHS has proposed a national coverage determination that would remove all cost sharing in Medicare if finalized for any Medicare participants receiving PrEP, as well, by the way, as the proposed NCD also covered all the wraparound services such as the STI testing, lab visits, et cetera, and increased the number of HIV tests from 1 test a year to 7 for Medicare participants. So I think that we have been really clear that this administration prioritizes PrEP in many ways. The rules that I mentioned around healthcare discrimination do guarantee access to care in many ways that you mentioned. So providers can't say, we're not going to provide PrEP to our patients because we have a religious objection to people on PrEP for sexual reasons. Like they can't say that, they also can't say that they're not going to provide PrEP to certain parts of the community because of their biases about who needs PrEP. And our other work around access to care, we have a privacy rule, a HIPAA privacy rule that was just strengthened that guarantees privacy in the healthcare space. So I think that the combination of all of these rules really do address that. What I can't speak to is I can't speak to what state legislators or governors do. They're not part of the federal government. They're a different system of government. From the federal side, we are very clear that PrEP is safe and highly effective, and we want it available to anyone who needs it. And we have continued to make that very clear, and we'll continue to do so because PrEP is, my boss, Admiral Levine, she calls it a medical miracle. She says that if PrEP existed 40 years ago, the landscape of HIV would have looked incredibly different in this country. And so we still have this problem, though, where we have tools that are scientifically proven to be very effective, but they're not able to be accessed by everyone who needs it or wants it. And so we're trying to address the racial disparities in how PrEP is accessed, as well as geographic disparities. Like the U.S. South, for example, has lower PrEP usage than, for example, places like here in Chicago or New York. So we are very much continuing to work to advance PrEP, to try to advance, reduce and eliminate disparities in PrEP, and to protect and safeguard people's access to it when they need it. Yeah. I'll follow where the mic is.
Hi, good morning. For those of us that are learning, can you talk a little bit more about that 504 rule, please? Thank you.
Yeah. So Section 504 of the Rehabilitation Act is basically the legal protections around disability in healthcare. And there's other parts of it too that are outside of that. But for this purpose, I'll talk about that part. So Section 504, disability protections in healthcare. We just finalized this rule. It's the first regulatory update since I think 1977. Is that right? Yeah. So it's it's a long time. It's a very long time. It's also before HIV was really known to our world, right? In the ways that we talk about disability protections today versus 1977, just in general, are incredibly different. ADA hadn't been passed in 1977, so it's a very different world today. This update has a couple components that specifically focus on people living with HIV. One is saying that regardless of if a person living with HIV has the exact language it used was presumptive. If there's symptoms that would lead somebody to be visibly needing disability services, that's like very clearly covered under 504 before. But under this rule, it says anyone living with HIV is presumptively protected by these disability protections. So if you're living with HIV, you are legally protected by this regulatory update, regardless of what your CD4 count is, for example, right? So it's not only if there's someone who has a very linear idea of what disability means. It's actually anyone who might need protections, visible or invisible, and that's kind of our understanding of disability today, right? Is that not all disabilities are visible, and so that's the first part. The second part is that providers can't say that I'm uncomfortable with providing, I'll just use dental care or any other kind of care for a person living with HIV because of their own kind of misinformation about HIV, right? So that's not okay. Just like they can't do that for any other kind of disability. And we recognize that not everyone who lives with HIV identifies as disabled, and that's identity is not really the central part here. The central piece here is about the legal protections, because you don't have to identify as disabled to sometimes be mistreated by a provider. And so this is saying that regardless of how you identify, if you're a person living with HIV, you have these legal protections. Okay. Yeah. Yeah. Um, yeah.
Thank you for 988. I used it recently, and I give resources all the time, but it was a close friend who is suffering, and I kind of freaked out. And I called it, and they were incredibly helpful and thorough and gave a lot of resources, very welcoming. Sometimes calling those three numbers, you think they're not going to be really that helpful, but it really was. So thank you.
Yeah. So just to underline for everyone, 988 is available for the person calling or for the person they're calling for. And it is very short wait times when people call, usually less than 30 seconds to get someone on the phone. I don't know about you, but that's faster than like when I try to get my family on the phone. So that's very, very quick answer, and absolutely trained in crisis care. So I'm glad it was available for you, and please continue to share about 988. Yeah, it's available by call, text, and chat.
Thank you. Thank you so much for all your comments, and thank you for the work you've done beyond this. I met you in Allentown at the LGBT Center with ACT UP Philly. That was some years ago. But I'm glad to hear that you're on PACHA. And the question I want you to ask is about President Biden's national HIV/AIDS strategy and the quality of life indicators for long-term survivors that goes beyond blood work. Is any of that, or those suggestions that we gave are going to be a part of the national AIDS strategy? What are the indicators of quality of life beyond blood work for long-term survivors?
Yeah. So, and nice to see you again as well. I think I'm understanding the question, but let me know if I got this wrong a little bit. So, the National HIV/AIDS strategy in this administration really takes a hard look at quality of life measures, whereas prior strategies focused much more on the prevention side, and we do both. Also, I think it's a false dichotomy between prevention and care. These are things that are very linked. But on the quality of life side, a big focus is about supporting people as they age. So aging with HIV, and helping to prepare the aging systems that we have in the U.S. to better provide the support. Yes, the medical support, but also the other types of support for people living with HIV as they age. So some of that might look like training. Some of it looks like legal protections. There's different components of it that kind of fit together to try to ensure that as people age with HIV, that they're cared for. And that's a big part of the quality of life. That I would say that's the central element of the quality of life piece in NHAS, National HIV/AIDS Strategy, is to prioritize people living with HIV as they age. Yeah. Yeah. Yeah.
All right. Thank you so much for joining us and being with us today and sharing all of this great information, and including spotlighting some really important developments that have been emerging from the Biden administration. I am focused, especially in my own work, on the need for more response to the very extremely high rates of unemployment and poverty among people living with HIV, which of course connects very closely to the quality of life issues. The CDC's most recent reports from their HIV data surveillance show that 39% of us living with HIV are outside of employment. which almost identically matches the 38% of us that are living in poverty. And with all of the really tremendous advances in HIV that we have seen, we've been unable to see more than the most limited response from the federal government to this impact on our lives and our well-being, and the complexities of all of the policies that make it very difficult for people to consider and pursue employment. And I really hope to hear about work that's being done to intensify the focus within the federal government so that we don't have to glide through our lives living with HIV in poverty and outside of full inclusion in the communities that we live in.
Thank you for that question. There's part of it that I can try to answer, and then part of it is I'm going to ask if my colleagues can remind me to follow up afterwards, because there's a part that's kind of about other federal agencies that I can't speak to. But the biggest, in my opinion, the biggest support from the federal government to support low-income people living with HIV is Ryan White, in addition to HOPWA, which is also really critical, but it's outside of HHS. So I can't speak to HOPWA. But the Ryan White program is, and I ran a Ryan White agency in California. I'm familiar with the challenges of a system that's funding has not greatly increased over time, right? But the folks that are running the Ryan White program are doing incredible work to try to really address exactly what we're talking about, which is to access the resources, to ensure that people who need these resources the most can access them. I do recognize the challenges. A lot of that has to do with the funding levels. They have worked really hard to try to remove structural barriers within the program and to try to get care where it's needed. I think the biggest challenge there is the funding levels, and so we keep seeing that. But if we can just try to follow up with maybe Department of Labor and also ONAP, we can try to get, and if we can get your contact info, I'd be happy to try to make sure that we can get you some additional answers, and just maybe HOPWA too for HUD. Thanks.
We have time for one more question.
Hello, Adrian. Thank you so very much for coming here today and sharing vital information as well as life-saving information. Once upon a time, there was nothing. Advocacy and activism have got us to where we are now. Next to ensuring that we vote later on this year, how can we work in partnership with Mr. Carboni and yourself? Because it took collaborative efforts to get us to where we are now.
So I cannot speak about elections, but I would say in general, so not speak about elections, in general, it's important that people living with HIV raise their voice and be heard in lots of different spaces. So I'm actually explicitly not talking about elections, but in general, it's important that people's voices are heard. I can tell you that, like, when we put out drafts of whether it's clinical guidelines or rules or other stuff like that, we ask for public comment, and some of these things get an enormous amount of public comment, like in the thousands, and some of them don't. Some of them get like tens of comments. So comments can actually really make a difference, and lifting your voices up and telling us what you think as an organization or multiple organizations that work together, or even as individuals. When people living with HIV express your views to us about whether it's quality of life, or whether it's specifically focused on aging, or whether it's focused on discrimination or poverty, as the last person asked about, it does help us with our prioritization. And we actually, for rules, for regulations, we are actually required to read and respond to every comment, which is why some of the rules take so long. Because when they get tens of thousands of comments and everyone's being read, it take a little while. But it's for a good reason. It's to make sure that our process is community informed. So I would say on the official government side, which is that's how I'm here today, so how I'm allowed to answer, I would say that it's important that you see yourselves as partners with the federal government. And I will say that before joining the government, when I was running nonprofits, I don't know that I thought about the government that way. I don't know that I thought about it as like, they want to hear from us. But I can tell you with all authenticity, Sanford, right now, that when we put out public comment, we are very eager to hear from the community at large, and we welcome those comments and really do take them to heart. So I would say that is the best way to be in partnership with us in terms of helping to advance our shared goals around equity in all of this work. Yeah, thanks.
Thanks so much. We did have one question from Dr. Green. If there's a listserv or a newsletter that people can sign up for or that we can share.
Like a newsletter from the government. Okay, I'm not sure about a newsletter, but I'm happy for
Or listserv.
Yeah. So Jeff and Sanford, they have my email. So if there's folks that have follow-up questions, if they're policy related, you could feel free to reach out. But I would also say that if they're about local programs or services, please connect with Commander Trail and with Michael, because they're going to be better able to address local questions than I would be.
The handouts that I'm leaving with HRSA over here on that back wall, I'll leave a few of my cards also. So feel free to pick one up.
Might as well take two. I'll leave mine over there too. Thank you.
Great. Well, once again, thank you, Senior Advisors Shanker, Director Kabanargi, and Commander Trail. We really thank you for being here today and for sharing your efforts that you're doing on the national level, the federal level. Thank you so much.